drug. Psychotic. What is psychosis? So psychosis means when there is problem in the, it is basically a mental illness where there is distorted or non-existent sense of reality. So reality sense is changed in case of the psychosis. So there are different types of the common psychotic disorders. One of them is the mood disorder, which is the major depression or mania with psychotic features. Next is substance induced psychosis. Next is dementia with psychotic features, delirium with psychotic features, brief psychotic disorder, delusional disorder, schizoaffective disorder and schizophrenia. Of these, the most common, and probably you will know about the term schizophrenia. So many of patients have schizophrenia, and you will encounter many of these patients who are wrongly diagnosed as different other categories. So these are schizophrenia is also a spectrum of disorder where the different types of the psychosis is present. The antipsychotic drug used primarily to treat schizophrenia, but it is also effective in other psychotic and manic states. It is not curative and do not eliminate chronic thought disorder, but they often decrease the intensity of hallucinations and delusions and permit the person with schizophrenia to function in a supportive environment. So schizophrenia is a disorder that cannot be fully cured, but with medications it can be controlled. So that's why the importance of the antipsychotic drug is there. So it is a chronic psychosis characterized by delusion. Delusion means false belief in something. Hallucinations, often in form of the voices, that is, there is no real voice or no real scene is there, but the patient or the person is experiencing that some voices or some views are in front of them. So this is known as the hallucination. And thinking or speech disturbance. So disturbance in thinking and speech, and there is some distortion in the reality. That is, the person cannot distinguish what is the reality and what is going on within their mind. The onset of illness is often during late adolescence or early adulthood. It occurs in about 1% of the population and is a chronic and disabling disorder. Schizophrenia has a strong genetic component. In most of the cases, there is some history of psychosis in their grandparent or parents. Probably reflects of fundamental biochemical abnormality, possibly a dysfunction of the mesolimbic or mesocortical dopaminergic neuronal pathway. So here the problem lies in the dopamine neurotransmitter. So this is the classification of the antipsychotic drugs, broad classification. So this is according to their chemical structure. So this may be phenothiazine, butyrophenones, thiazanthines, other heterocyclics, and these come under the typical antipsychotics, and these are the atypical antipsychotics or the newer antipsychotics. Within the phenothiazines, there are different types of the side chains. The most common drugs that can be used are the chlorpromazine, triflupromazine, thioridazine, trifluperazine, and fluphenazine. Of this, the chlorpromazine is the parent drug, of which the different investigations have been done, and you will often encounter that thioridazine or fluphenazine can be used even nowadays. Apart from this, there is haloperidol, trifluperidol, penfluridol. This comes under butyrophenones, of which haloperidol is the most common drug still used now. Thiazanthines is example is the flupentixol. There are some other heterocyclic compounds like pimozite and loxapine. This all comes under the typical antipsychotic drugs. But again, like that of the antidepressant drug, there are different more adverse effects of these typical antipsychotic drugs. Most common is the extrapyramidal side effects. We will come to this later. That's why there are newer categories of the drugs. This comes under the purview of atypical antipsychotics who have lesser extrapyramidal side effects, but they have more metabolic side effects. Example of the clozapine, risperidone, olanzapine, quetiapine, aripiprazole, ziprasidone, amisulpiride, and zotapine. Of this, clozapine, risperidone, olanzapine, quetiapine, aripiprazole, these five are very indiscriminate, very commonly used drugs, and there are some specific advantages and adverse effects also with these drugs associated. We will discuss about this. These are very important. These atypical antipsychotic drugs. So antipsychotic drugs, first typical or atypical, or in other words, first and second generation. The first generation drugs may be low potency or high potency. There are different chemical structures already you have seen, and these may be high potency or low potency drugs. Ultimately, all these based upon the dopamine overactivity hypothesis. This hypothesis led to the development of this type of the antipsychotic agents. So there are some dopamine overactivity in the neurotransmitter junction. So we have to decrease to decrease the schizophrenic symptoms. There are another term known as the neuroleptic. Neuroleptic is basically refers to these typical antipsychotic drugs. Those acts through these dopamine pathways. They mainly acts through D2 receptor blockade. So they are blocking the dopamine D2 receptors that is present in the postsynaptic neurons, mostly in the mesolimbic and mesocortical pathways. But they are associated with the extrapyramidal side effects. Time and again I am saying, so typical or first generation antipsychotic agents, these are the first discovered, these are potent most of the cases, but there are some typical adverse effect known as the extrapyramidal adverse effect. And this extrapyramidal adverse effect develops due to dopamine blockade. These drugs mainly blocks the dopamine D2 receptors in the postsynaptic neuron in the mesocortical and mesolimbic pathways. So these are conventional, typical or traditional antipsychotics, same thing. They are competitively blocking the dopamine D2 receptors. Time and again I am saying this is very important. So they are blocking the dopamine receptors. Antipsychotic drug, typical antipsychotic drug or first generation antipsychotic drug, common mechanism of action is the dopamine blockade. Which receptor most commonly blocks? The D2 receptors. Most likely they are associated with different types of the extrapyramidal symptoms. So there are extrapyramidal fibers and pyramidal fibers. You have already read in the physiology. So there are some movement disorders that generate due to extrapyramidal symptoms. Again, this generates due to the dopamine receptor blockade in different pathways. So drugs, these are tightly bound to dopaminergic neuroreceptors. Those drugs which are more tightly bound and which are more potent, like that of the haloperidol, they give rise to more extrapyramidal symptoms. And these extrapyramidal symptoms are very detrimental for the patients. The patient cannot continue their normal daily activities because of different types of the movement disorder, disabling symptom. Okay. So second generation antipsychotics came, or atypical antipsychotics or second generation antipsychotics, these are similar in terms. They have lower incidence of the extrapyramidal symptom than the first generation agents, but are associated with a higher risk of metabolic side effects. So remember, the extrapyramidal side effects that is associated with the typical or first generation antipsychotics is very less or not present in second generation or atypical antipsychotic, but there is more metabolic side effects with these atypical antipsychotic agents. Metabolic side effects means there is more chances of the hyperglycemia or diabetes, hypercholesterolemia, that is the cholesterol levels can be increased, and weight gain. So these are metabolic problems. Unique activities of this type of the drugs are the blockade of the both serotonin and dopamine and perhaps other receptors. Basically, they have lesser activity on dopamine receptors in other pathways, but they are blocking the serotonergic receptors in some other pathways, and together they are gives rise to this type of the effects. Second generation agents are generally now the first line therapy for the schizophrenia. When a patient with schizophrenia diagnosed, usually we start with the atypical or second generation antipsychotic agents to minimize the risks of debilitating extrapyramidal symptom which is associated with first generation drugs that act primarily at the dopamine D2 receptor. They exhibit an efficacy that is equivalent to or occasionally exceeds that of the first generation antipsychotic drugs. So previously it has been seen that the first generation drugs are more potent, but with newer development of the atypical antipsychotic drugs, the safety is more ensured and efficacy is also ensured. They are become more efficacious. That is with age. So there are some differences in the therapeutic efficacy among the drugs have not been established. So we can interchange one drug with the other if the patient is not responding to one type of the drug. So individual patient response and comorbid conditions are the important thing which we should keep in mind while first starting with the antipsychotic drugs. But there are some refractory patients, that is we are giving the different atypical antipsychotic drugs also, but the patient is not responding. Approximately 10 to 20% of the patients with schizophrenia have an insufficient response to all first and second generation antipsychotics. For these patients, clozapine has been shown to be an effective antipsychotic with a minimal risk of extrapyramidal symptom. Clozapine is the first atypical antipsychotic agent, but there is a typical adverse effect known as the agranulocytosis. We will come to this later. Because of this atypical agent is lesser used now, but in refractory schizophrenia patients where the patient is not responding to other atypical or typical antipsychotic agents, clozapine is the drug of choice. So remember, clozapine is mainly used now in case of the refractory schizophrenia. However, its clinical efficacy is limited to refractory patients because of serious adverse effect already I have discussed, like bone marrow suppression. This bone marrow suppression ultimately gives rise to the agranulocytosis. That means granulocytes, the granulocyte generation becomes less from the bone marrow. That's why agranulocytosis. Okay, so ultimately that leads to different types of the aplastic anemia. Seizures can occur, epilepsy can develop, and cardiovascular effects like orthostasis. Orthostasis means there is sudden change in blood pressure when the patient changes the posture, that is from the supine position to the standing position, like that. So these are the problems with the clozapine. That's why clozapine is lesser used now within the atypical antipsychotic agent group, but it is used in case of the refractory schizophrenia. This is important. Okay. So mechanism of action, dopamine antagonism is the more common mechanism of action. Already we have time and again discussed. Most first generation agents and most of the all the first generation agents and most of the second generation agents cause the dopamine blockade, D2 receptor blockade in the brain and the periphery. And apart from this, the serotonin receptor blocking activity is also seen in most of the atypical antipsychotic agents. They can block the different types of the 5-HT receptor, for example, 5-HT2A receptor. And like that of the antidepressants already we have discussed in the Friday, there are different other agents can block the different other receptors to some extent also. For example, clozapine, that clozapine have high affinity for, apart from D2, there is high affinity for D1, D4, 5-HT2, muscarinic and alpha adrenergic receptors also, and they have weak dopamine D2 receptor antagonist, but they have more action on the 5-HT2 antagonist, 5-HT2 receptor, that is the serotonin. Risperidone is another drug that blocks the 5-HT2A receptor. So these are the differences between the different agents. So mechanism of action, same thing. So this is the dopaminergic neurons. Dopamine is released, and if we are giving these antipsychotic drugs, dopamine cannot bind with the dopamine receptor, most commonly the D2 receptors in the post-neuronal receptors. So there will be dopamine receptor blockade and decreased intracellular response. So schizophrenia or different types of the psychosis is mainly based on this dopamine overactivity hypothesis. So there are more dopamine availability, we are decreasing the dopamine in the neurotransmitter cleft. So this is in contrast to the antidepressant drugs. In the Friday we have studied about the antidepressant drugs. They are increasing the availability of the norepinephrine and the serotonin in the neuromuscular cleft, in the neuromuscular junction cleft. Okay. So they are increasing the availability of the monoamines in antidepressant drug. These are the difference. Antipsychotic drugs, they are decreasing the action of the dopamine, another neurotransmitter, on the dopamine receptor. So if we can remember these two, it will be easy, the mechanism of action. The very important mechanism of action of antidepressant and antipsychotic agent. So you should not jumble up with these two. So it is clear, antidepressant, antipsychotic. They are increasing, they are decreasing. So risperidone blocks 5-HT2A receptor to a greater extent than it does D2 receptor, as does olanzapine. So these are the difference, and accordingly the schizophrenia is again a spectrum of disease where the different symptoms are different. So we can use the different drugs according to the symptoms which receptor they are blocking. Aripiprazole is a drug which is a partial agonist at D2 and 5-HT1A receptor as well as an antagonist of 5-HT2A receptor. Quetiapine is another drug which blocks the D2 receptors more potently than 5-HT2A receptor, but it is relatively weak at blocking either receptor. That is, they are weak blockade, but they are more potently blocking the 5-HT2 receptors. Its low risk of extrapyramidal symptom may also be related to the relatively short period of time it binds to the D2 receptor. So when we need very less amount of the extrapyramidal symptoms, we can use the quetiapine. So again, what I am discussing, so this is the relative affinities at the D2 receptor. So clozapine, you can see, this is the low affinity end, this is the high affinity end. Haloperidol is a typical antipsychotic agent. They have very high D2 receptor affinities, very high. Chlorpromazine is also very high. This is also a typical antipsychotic. Clozapine is the atypical one, but the first atypical one which have lesser D2 receptor affinities. So most antipsychotic drugs have affinities at D2 dopaminergic receptors that parallel clinical potency, and clozapine differs from typical antipsychotic drugs in having a similar affinity for both D1 and D2 receptors. So for D1 receptors, you can see there is more affinity for the clozapine receptor, and for chlorpromazine and haloperidol, these are the typical antipsychotic, D1 receptor blocking property is less. So D2 is the main blocking property of the typical antipsychotic, but this clozapine or atypical antipsychotics also blocking the D1 receptors more rather than the D2 receptors. So the actions of these antipsychotic drugs, the clinical effects appear to reflect a blockade of the dopamine or serotonin receptor. So dopamine or serotonin receptor ja kore, ja function, we are blocking these functions because there is some exaggeration of the symptoms due to the overactivity of this neurotransmitter. So many of these agents also block, like that of the antidepressant, they are also blocking cholinergic receptors, adrenergic receptors, some histaminergic receptors. So they also give rise to similar type of the adverse effects like that of the antidepressants. So ultimately, the pharmacological actions on those receptors is the cause of the adverse effect of both antidepressant drug as well as the antipsychotic drugs. So in a nutshell, you can see antipsychotic drugs, like they can act on the cholinergic or muscarinic receptors, particularly thyroidazine and chlorpromazine. Thyroidazine and chlorpromazine, these are the typical antipsychotic drugs. They are blocking the muscarinic receptor. That's why some anticholinergic adverse effect can develop more for these agents. Particularly chlorpromazine, they are blocking the alpha adrenergic receptor. That's why some postural hypotension or different problems with the pressure, blood pressure can happen with this. All antipsychotic drugs, but particularly haloperidol, fluphenazine and thiazixone, they block the dopamine receptors more. That's why there will be more extrapyramidal side effects. Risperidone, clozapine, these are the these are atypical antipsychotic agents. They are blocking the serotonin receptor. Time and again I am saying. Some antipsychotic drugs, particularly chlorpromazine and also clozapine, that is both typical as well as atypical antipsychotic agent. Some agents can block the histamine receptors. So when histamine receptor is blocked, there will be sedation. Sedation can happen. So from this nutshell, this is similar to the antidepressant drugs. So they can block different other receptors also that give rise to different adverse effects. So antipsychotic effects, how these antipsychotic effects happen? So schizophrenia, there are basically two types of the symptoms. One is known as the positive and another is the negative symptoms. So positive symptoms are hallucination and delusions more commonly. All antipsychotic drugs, they can reduce these positive symptoms of hallucination and delusion quite effectively by blocking this D2 receptor in the mesolimbic system of the brain. But there are some other symptoms of the schizophrenia also, like negative symptoms known as the blunted affect, apathy and impaired attention. So blunted affect, so the patient become indifferent to the surroundings. There may be apathy, there is no pain or no emotions, impaired attention as well as cognitive impairment. All these are negative symptoms, but they are not very much responsive to therapy, particularly with the first generation antipsychotic agents. So they are responding slightly to the second generation antipsychotic agents or atypical antipsychotic agents, but they are not responding at all to the first generation or typical antipsychotic agents. Many second generation agents like that of the clozapine can ameliorate the negative symptoms to some extent. Again, to those schizophrenic patients who are showing more negative symptoms, we should use the clozapine, in spite of clozapine having different types of the adverse effects. So those patients who have negative symptoms, in case of the schizophrenia, the morbidity and mortality is also very high. So with schizophrenia psychosis, there is also risk of the suicide, and there are some different types of the indices like completed suicide, that is some persons complete suicide, some are just trying again and again. So the percentage of the completed suicides are more with those schizophrenia or psychosis patients who are having more negative symptoms. Okay, so in those cases we should treat judiciously. If we need, we should use the clozapine, in spite of clozapine having very different types of the adverse effects. But those schizophrenia who have the common symptoms, the positive symptoms, hallucination or delusion, they are basically easier to treat. Okay, so negative symptoms is difficult to treat. That is the take home message. Extrapyramidal effects, what I am talking from the beginning, that is the problem of extrapyramidal side effects because this dopamine receptor blockade. There are different types of the problems, like there may be dystonia. Dystonia means tone is changed, sustained contraction of the muscles leading to twisting, distorted posture. So the posture or hand posture, leg posture can be some twisted or distorted, and the patient can remain as it is for some minutes to hours. Yeah. This can happen due to the drug. Okay. Parkinson-like symptoms. You will read about the Parkinsonism later. So rigidity, there is bradykinesia, and there is tremor of the different types of the muscles. The patient cannot walk without having any tremor. So this is known as the Parkinson-like symptoms. This can happen. Parkinsonism means motor restlessness. Motor restlessness means the patient cannot stand or cannot sit in a place for some time. He or she is continuously moving around. This is known as the akathisia. And there is the tardive dyskinesia. Tardive dyskinesia means involuntary movement of some parts of the body. Like there may be tongue, lips, neck, trunk and limbs. Probably you have seen some movies or something where there are some spin rolling activity, some persons doing something like something grimacing is continuously doing. So these are basically different types of the symptoms. These are extrapyramidal symptoms, and if this becomes more, you should suspect that the drug, okay. Blockade of the dopamine receptors in the nigrostriatal pathway probably causes these unwanted movement symptoms. So we are blocking the dopamine receptors in the mesolimbic and mesocortical pathways for the beneficial action. But these drugs, mainly the first generation drugs, also blocking the dopamine receptors in the nigrostriatal pathway. And this nigrostriatal pathway dopamine blockade ultimately gives rise to this type of the movement disorders. Okay. So this is the cause of the unwanted side effects. The second generation antipsychotics exhibit a lower incidence of the extrapyramidal effect. Next, coming to the antiemetic effect, with the exception of the aripiprazole, most of the antipsychotic drugs have antiemetic effect. Many of the schizophrenia patients are continuously vomited, and there is some antiemetic effect are there with some agents. Anticholinergic effects already we have seen because they are blocking the cholinergic receptor. There are some atropine-like effects like thioridazine, chlorpromazine, clozapine and olanzapine. There may be blood vision, dry mouth, confusion, inhibition of the gastrointestinal and urinary tract smooth muscle. There may be leads to constipation, or there may be urinary retention or constipation. This can develop as a side effect. The anticholinergic effects may actually assist in reducing for some agents where there is orthostatic hypotension and lightheadedness. Orthostatic already discussed, when the posture is changed, alter temperature regulating mechanism and can produce poikilothermia. That is the condition in which the body temperature varies with the environment. So poikilothermic means the body temperature is not in accordance with the body temperature is in accordance with the outside temperature, but it should not be there. So person becomes poikilothermic. In pituitary, it is also blocking the D2 receptor. When in pituitary D2 receptor blocking occurs, there is increase in the prolactin release. So prolactin is a hormone that is released from the pituitary, that is increased in some of these patients due to this agent drugs. Sedation occurs due to the histamine receptor blocker, particularly with chlorpromazine, olanzapine, quetiapine and clozapine. Sexual dysfunction may also occur with antipsychotic due to various receptor binding characteristics. This is similar to the antidepressant drugs. Some distinctive feature like triflupromazine. Triflupromazine is more potent than chlorpromazine. Chlorpromazine is the prototype drug, but lesser used nowadays. Thioridazine is a low potency phenothiazine having marked central anticholinergic action. Thioridazine have more anticholinergic action, that is blood vision, dry mouth, etc. Triflupromazine, fluphenazine have minimum autonomic action, means the blood pressure changes will be minimal. Haloperidol is a potent antipsychotic. It is used now. It is a typical antipsychotic agent, the preferred drug for acute schizophrenia. আমরা যেটা দেখি acute schizophrenia প্রচন্ড ভায়োলেন্ট হয়ে গেছে, একদম রাখা যাচ্ছে না বা ওয়ার্ডে নিয়ে আসা হয়েছে, তখন কিন্তু আমরা তাকে হ্যালোপেরিডল ইনজেকশন বা ইনফিউশন দিই যাতে যেটা ইমিডিয়েটলি কমে। So haloperidol can be used in case of the acute schizophrenia, acute episode of the schizophrenia. Huntington's disease is another movement disorder, is a genetic disorder, and Gilles-Dillard Tourette syndrome. Tourette syndrome is another movement disorder where there is some dystonia. These are different types of the neurological diseases where the movement disorder occurs, and that mainly controlled acutely by means of the haloperidol. So remember, within the typical antipsychotic, haloperidol is the most commonly used, and mostly it is used in the acute cases, not in the chronic cases. Phenfluridol is recommended for chronic schizophrenia, affective withdrawal, and social maladjustment. So it is used where the psychosis is associated with social maladjustment or some affective withdrawal. So in those cases, phenfluridol can be used. Atypical second generation antipsychotics, already we have seen the dopamine receptor blocking is less, and this is very less in case of the nigrostriatal pathway. That's why the extra pyramidal side effects, that is the different types of the movement disorders, are very less, like tardive dyskinesia, dystonia, akathisia. These are very less. Extrapyramidal side effects are minimal, and they tend to improve the impaired cognitive function in psychotics. So cognitive function, cognition, they becomes diminished, blunted in case of the schizophrenia. That can also be increased by means of these atypical antipsychotic agents. But there are problems with the metabolic side effects. Already we have discussed, we are coming. So clozapine, we have discussed something about this. This is the first atypical antipsychotic, weak D2 blocking action, produces few or no extrapyramidal symptoms. Tardive dyskinesia is rare, and prolactin level does not rise. Both positive and negative symptoms of the schizophrenia are improved, and clozapine is the most effective drug in refractory schizophrenia. So clozapine is a drug that is used in refractory schizophrenia. Clozapine is the drug that is used where the schizophrenia is associated with more negative symptoms, blunted affect, anhedonia, apathy, etc., etc. The differing pharmacological profile may be due to its relative selectivity for D4 receptors. Basically, when on inspection on different types of the binding studies, it has been seen that they have more affinity for the D2 receptors and 5-HT2 and alpha adrenergic blocking action. And they are quite sedating because they have significant H1 blocking action, moderately potent anticholinergic, but paradoxically induces hypersalivation. It has been seen, that is the hypersalivation, saliva is increased more. So clozapine, this is about the clozapine, and it is metabolized by the cytochrome enzymes. So there may be some drug-drug interactions are there, and major limitation, already I have told once or twice. So this is very important. Clozapine is very important for your exam also, and this adverse effect. So agranulocytosis is associated with clozapine, approximately 0.8%, quite high incidence, and also different types of the blood dyscrasias. That is, in the bone marrow, the blood corpuscles are not formed well. That's why this agranulocytosis or other blood dyscrasias occur. What we have to do when we are prescribing the clozapine, we have to regular monitor the leukocyte count. So WBC count, total count, আমরা যে লিখি, যদি আমরা ক্লোজাপিন দিতেই হয়, যেমন রিফ্র্যাক্টরি স্কিজোফ্রেনিয়া বা নেগেটিভ সিম্পটম থাকলে, সেক্ষেত্রে ক্লোজাপিন দেওয়ার পর পেশেন্টকে কিন্তু নিয়মিত ইন্টারভ্যালে WBC কাউন্ট করাতে হবে. If the WBC count becomes less, so we have to stop the clozapine or change to other drugs or decrease the dose of the clozapine. So this is very important. And metabolic complications, it is present with all atypical antipsychotic agents like that of the clozapine also. So there may be weight gain, hyperlipidemia, hypercholesterolemia, precipitation of the diabetes is another major limitation. So in the endocrine chapter, you will read about the diabetes. So remember, there are some drugs that can precipitate diabetes also. They can increase the blood glucose level, hyperglycemia. So those patients who the hyperglycemia is at the borderline, so there may be precipitation of the diabetes. So if you are asked about the example of one drug that can precipitate diabetes, the example is the atypical antipsychotic agents. These atypical antipsychotic agents can precipitate diabetes. So again, when we are prescribing the atypical antipsychotic agents, we have to regularly glucose level also. Similar. So total also lipid profile to see whether the cholesterol triglyceride are within the normal limit or not. High dose can induce seizures even in non-epileptics. There may be some sedation because it is H1 receptor blocker, unstable BP, tachycardia, urinary incontinence can happen. Clozapine is basically a reserve drug now for refractory schizophrenia. Risperidone is another commonly used drug. It causes D2 and 5-HT2 receptor blockade. In addition, it is also blocking the alpha-1, alpha-2 and H1 receptor. Blood pressure can rise if it is used with a selective serotonin reuptake inhibitor. This you have to remember because in the antidepressant chapter already we have seen SSRI. We have read about SSRI, selective serotonin reuptake inhibitor in the Friday. So it is a very important drug. In many of the cases, the psychosis is associated with depression. So we have to combine 2 drugs or 3 drugs. In that cases, we have to keep in mind that if the SSRI is combined with risperidone, the blood pressure, sudden rise of the blood pressure can happen. Risperidone is more potent D2 blocker than clozapine. Extrapyramidal side effects are less. Prolactin levels can rise disproportionately during therapy. This is more or less similar to all the agents. Weight gain, incidence of the new onset diabetes can happen, but it is less in comparison to the clozapine, and there may be some increased risk of stroke in the elderly. So the newer antipsychotic drugs, the adverse effects are similar, but the incidences are the lesser. Olanzapine is another very commonly used drug. It resembles clozapine in blocking multiple receptors like D2, 5-HT2, alpha-1 and alpha-2, H1 and muscarinic receptor. That is, different types of the receptors are blocked. Both positive and negative symptoms of the schizophrenia are also controlled by the olanzapine. Olanzapine is a newer drug where some part of the negative symptoms are also controlled. Schizoaffective disorders are also controlled, and it is also approved for use in mania. Schizoaffective disorder, that is, again, the schizophrenia is a spectrum of disorder where some affective disease component may be there. It is known as the schizoaffective disorder. It is a potent anti-muscarinic, so dry mouth, blood vision, constipation, urinary retention, all this can happen. Weak D2 blockade, that's why the similar thing, fewer extrapyramidal side effects. It causes weight gain, higher risk of impairing glucose tolerance. Again, the chance of the diabetes precipitation is there. Increased incidence of the stroke may be increased in the elderly. So all these olanzapine or risperidone, the stroke rate is increased in case of the elderly. This is also we have to keep in mind. Quetiapine is another drug used which basically requires twice daily dosing. It blocks the 5-HT1A, 2, D2, alpha-1, alpha-2 and H1 receptor. They have some extrapyramidal hyperprolactinemic side effect, but this is lesser. Sedation, postural hypotension, urinary retention, these are more or less similar to the other ones. But there is a typical adverse effect is the QTC prolongation. So in the ECG, there are QTC interval can be calculated. This is increased when we are using the quetiapine. That can lead to cardiac arrhythmia, and if the cardiac arrhythmia becomes more, that can lead to death also. So remember, quetiapine is associated with QTC prolongation. Okay. So no benefit to negative symptoms of the schizophrenia. It is effective in acute mania as well as bipolar depression, because of which it is frequently selected for maintenance therapy. So those psychosis patients where there is some bipolar component, we should use the quetiapine. But again, for this QTC prolongation, every patient where we have to prescribe the quetiapine, first the patient is asked to do a ECG. So ECG is mandatory for the quetiapine therapy. For all the antipsychotic drugs, it is better to do a ECG to see whether the QTC is already prolonged or not. If the QTC is already some prolonged, we should not use these drugs. There are some other drugs, you will read later about some antibiotics that also increase this QTC. So QTC prolongation, quetiapine, just remember. Aripiprazole is another drug which is a partial agonist at D2 and 5-HT2A receptor and antagonist at 5-HT2 receptor. More or less similar to all this, but remember it is not sedating, may even cause insomnia. So most of the antipsychotic drugs cause sedation, but aripiprazole can cause insomnia. Extrapyramidal side effects, hyperprolactinemia, these are lesser. Again, here also some moderate prolongation of the QTC interval can happen. It is a long acting and it is also indicated in schizophrenia, mania and bipolar illness. So quetiapine is the most important drug where we have to do the ECG to see QTC prolongation. Next is the aripiprazole. Ziprasidone is the newer ones, more or less similar, but remember they have some anxiolytic and antidepressant property as well. So those patients who have psychosis as well as anxiety and depression, all this we can use the ziprasidone, and it is also indicated in mania. Details is not required, just remember the name and the indication about the ziprasidone. Amisulpiride. Amisulpiride is a congener of the sulpiride, high affinity for the D2 receptor. They have antidepressant property. This is not a sedative, and here is also QTC prolongation is seen. So this is important. So amisulpiride is also used now because they have some antidepressant property. So some psychosis with depression, we can use the amisulpiride. Zotapine is a newer one, but a different receptor blocking action is there. Just remember the name, details is not required. So adverse effects already we have discussed. So drowsiness within the CNS. So there may be drowsiness, lethargy, mental confusion may be there. Tolerance to sedative effect may develop. So there are some drugs who are very sedative, but with continuation of the uses, the sedative action ultimately decreases. Other side effects like increased appetite and weight gain already we have discussed, but it is not with the typical antipsychotic agents. Aggravation of the seizures in epileptics happen. This is also similar to that of the antidepressant drugs. Even non-epileptics may develop seizures with high doses of some antipsychotics like clozapine and occasionally olanzapine. In the CVS, postural hypotension already we have discussed. Palpitation, inhibition of ejaculation, that is sexual dysfunction can happen. All this happen due to alpha adrenergic blockade. More common with low potency phenothiazines, that is what with the typical antipsychotic agents. QTC prolongation, cardiac arrhythmia already we have seen. So QTC prolongation most commonly associated with the quetiapine, then aripiprazole. Risk of overdose, apart from this, thyroidazine, pimozide, diprasidone can happen. Excess cardiovascular mortality has been attributed to the antipsychotic drug therapy. So atypical antipsychotic agent in the elderly, there is increased chances of the stroke. This you also have to remember. Anticholinergic effects already we have discussed. Dry mouth, blurring of vision, constipation, all this can happen. Endocrine problems, hyperprolactinemia, since the prolactin release becomes more, already we have seen. And this hyperprolactinemia ultimately leads to amenorrhea, that is the menstrual period is suddenly stopped. Infertility can happen, galactorrhea and gynecomastia, all this can happen due to this prolactin. Okay. The atypical antipsychotics except risperidone do not appreciably raise prolactin levels. The similar thing, the atypical ones are there lesser. Metabolic effects already we discussed. So there is increase of the blood sugar level, increased blood lipid level, all this. There is high risk of precipitating diabetes or worsening it. So precipitation of the diabetes or worsening of the diabetes is common with the antipsychotic agents, more commonly the atypical antipsychotic agents, particularly olanzapine and clozapine. High potency drugs like trifluperazine, fluphenazine, haloperidol, and atypical agents like risperidone, aripiprazole and ziprasidone have low or no risk. That is typical antipsychotic agents, the metabolic side effects are very less, and within the atypical one, risperidone, aripiprazole and ziprasidone, these are the newer ones where these metabolic adverse effects are also less. Extrapyramidal disturbances already we have discussed. There are some more extrapyramidal adverse effects. So this is more prominent with high potency drug. High potency means they are typical antipsychotic drugs. There are Parkinsonism. Another extrapyramidal symptom is the rabbit syndrome. Rabbit syndrome is perioral tremor, যেমন rabbitরা করে. Acute muscular dystonia already discussed. Bizarre muscle spasm mostly involving the linguofacial muscles. Akathisia is the restlessness already discussed. Feeling of discomfort, apparent agitation manifested as a compelling desire to move about but without anxiety. So extrapyramidal adverse effects due to the antipsychotic agents, this is an important question. Okay. So these are the different types of the problems with this typical antipsychotic. Tardive dyskinesia and malignant neuroleptic syndrome, these two are also very debilitating. Malignant neuroleptic syndrome is associated with marked rigidity of all the muscles, immobility, the patient cannot move due to the marked rigidity of the muscles. Tremor, hyperthermia, because the patients become poikilothermic, that is why the temperature can be increased. Semi-consciousness, or the patient can go to the coma also. Fluctuating blood pressure and heart rate, and myoglobin in blood, that is the hemoglobin is broken down, the muscle within the muscle, and this myoglobin, if it is more, that can ultimately leads to acute renal failure also. This is known as the myoglobinuria, that is myoglobin is present in the urine and ultimately that can lead to acute renal failure. All this can happen under this malignant neuroleptic syndrome. So malignant neuroleptic syndrome is very problematic thing. Tardive dyskinesia occurs late in therapy, that is with years of usage. Here also purposeless involuntary facial and lip movements like constant chewing or pouting or puffing of the cheeks, lip licking or chorioattitude movements. So there is some repetitive actions of some muscles can happen due to this tardive dyskinesia. And when this happens, the daily activities, normal life leading becomes very difficult when these different types of the movement disorders happen. Hypersensitivity reactions are less, and remember again and again, I am writing again, agranulocytosis is associated with the clozapine, very important. Uses of the antipsychotics, different types of the psychosis like schizophrenia, primarily in functional psychosis, they have an indefinable but definite therapeutic effect in all forms of the schizophrenia, produce a wide range of symptom relief and control positive symptoms better than the negative symptoms. In case of the mania, they are required in high doses for rapid control of the acute mania, and mania patients tolerate them very well. Now the dose have to be individualized with titration of the symptoms. So we have to start with some atypical antipsychotic agent. For example, we should start with some risperidone or olanzapine, and then we have to build up the dose starting from the small dose. And in chronic schizophrenia, maximal therapeutic effect is seen after 2 to 4 months of therapy, more or less similar to the antidepressant effects. So again, we have to wait. We have to give the drugs and wait for some months to see whether the improvement is happening or not. And then we have to add some other drugs or delete some other drugs, increase the dose like this. Injected neuroleptics control aggressive symptoms of the acute schizophrenia over hours or few days. যেটা বলছিলাম, acute schizophrenia ক্ষেত্রে haloperidol most commonly injection দিয়ে দেওয়া হয়, প্রচন্ড অ্যাগ্রেসিভ হয়ে রয়েছে, রাখা যাচ্ছে না, সেক্ষেত্রে ইনজেকশন দেওয়া হয়, এবং তারপর ক্রনিক স্কিজোফ্রেনিয়ার ক্ষেত্রে ওরাল ট্যাবলেট বা ওরাল মেডিসিনস দেওয়া হয়। ইন আ ডিপ্রেস সাইকোটিক মোস্ট অফ দ্য কেসেস স্কিজোফ্রেনিয়া কোনো একটা সিঙ্গেল এন্টিটি নয়, তার সাথে কিছু না কিছু একটা অ্যাসোসিয়েটেড থাকে, সেক্ষেত্রে উই হ্যাভ টু অ্যাড সাম ট্রাইসাইক্লিক অ্যান্টিডিপ্রেসেন্ট অর সিলেক্টিভ সেরোটোনিন রিঅ্যাক্টেক ইনহিবিটর. Again, we have to keep in mind that which two drugs should be selected to combine or which two drugs should not be selected, whether the adverse effect is increasing or not, like that. So most commonly the SSRI, already we have discussed about the selective serotonin reuptake inhibitor. This is also the first line drug for the depression and quite safe. That's why in most of the cases we can combine the SSRI with this different types of the atypical antipsychotic agents, may be combined with relatively lower dose of an antipsychotic. So we should start with the lower dose of the antipsychotic, for example olanzapine, and then we should add another antidepressant drug. For example, we can start with the fluoxetine, like that. Anxiety, in some there are some anti-anxiety action but should not be used for simple anxiety because of the psychomotor slowing, emotional blunting, autonomic and extrapyramidal side effects. So what is the take home? That is, the antipsychotic agents should only be used when there is some psychosis component. It can decrease the anxiety or depression or something like that, but we should not use for these indications if this is present only as it is. As antiemetic, again these are potent antiemetic. Intractable hiccup and skeletal muscle spasm in some of the cases, alcoholic hallucinosis, Huntington disease, and already we have seen Gilles-Dilla-Tourette syndrome. These are the rare indications of the antipsychotic agent. So here the psychosis is not present, but antipsychotic agent can be used. So this can come as question that what are the areas, what are the indications of the antipsychotic agent where the psychosis is not present, we should give. So there are different types of the genetic neurological symptoms like Gilles-Dilla-Tourette syndrome, or in short only Tourette syndrome, Huntington's disease. These two are common. Here we can use the antipsychotic agents. Apart from this, intractable hiccup, continuous hiccup is going on, skeletal muscle spasm, different types of the rigidity not associated with the psychosis, alcoholic hallucinosis. In these cases we can use these antipsychotic agents. Mania. So anti-manic drugs are basically mood stabilizers. So we are stabilizing it in both of these ways, to in the middle, that is the normal or balanced mood. They are used in the treatment of mania both to control acute attacks and to prevent their recurrence. In mood cycling, but are not effective in treating depression. So remember, the anti-manic drugs or bipolar disorder not used for treatment of the depression, only in case of the mania or bipolar disorder. And also treatment of the some cases of the schizophrenia that is associated with bipolar disorder. So in bipolar disorder there is some undulation. So either there will be depression for some weeks or months and then mania for some weeks or months. Okay. So anti-manic drugs, within the anti-manic drugs the most important is the lithium. So you have to know everything about the lithium, very important. Apart from this, some anticonvulsant drug like carbamazepine, valproic acid and lamotrigine can also be used, and basically it is used more commonly now. You will read about the anti-epileptic drugs later. And some atypical antipsychotics already we have discussed, olanzapine, risperidone and clozapine. These three can be used in case of the bipolar disorder. And benzodiazepines, this can to calm the patient. So lithium is basically lithium ion is the oldest and best known mood stabilizing agent. Lithium salt is the lithium carbonate or citrate is the most commonly prescribed. 60 to 80% success in reducing acute manic and hypomanic states and reduces the risk of suicide related to bipolar disorder. Remember, suicide risk is maximum with the bipolar disorder, even maximum in comparison to the schizophrenia or depression. So those patients who have bipolar disorder, there is very high risk of suicide. So if we need to decrease the suicide, we have to treat the bipolar disorder, not only the depression, but we have to treat the bipolar disorder. So lithium is the best drug. It is used in the prophylaxis and treatment of mania, prophylaxis of and maintenance treatment of the bipolar disorder, and lithium augmentation is done in case of the recurrent depression in unipolar and schizophrenic patients in some of the cases where it is not responding to other agents. So how it is act? So neurotransmitter lithium carbonate is basically blocked in the post-translational modification of the receptor where the IP3 and the hormone-reduced CMP production happens. So IP3, inositol phosphate, they leads to different types of the signaling events. If we are blocking this, these signaling events are blocked. Again, there is cyclic AMP production, hormone-induced, that is also reduced when we are blocking the lithium, blocking this receptor by means of the lithium carbonate. So you can see the effect of lithium on the IP3 and the DAG second messenger system. So basically they are using in the post-receptor modification areas of the second messenger system where the second messenger is the inositol phosphate, IP3 and DAG. So they are blocking this IP3 and DAG related signal transduction. So ultimately you can see this is the normal signal transduction and we are blocking by means of the lithium. So when we are giving the lithium, the blocking occurs at the different parts of this IP3 and DAG second messenger system. So remember, lithium blocks the second messenger system IP3 and DAG, and this IP3 and DAG is related to the signal transduction. So lithium, by inhibiting the recycling of the inositol substrates, may cause depletion of the second messenger source PIP2 and therefore reduces the release of the IP3 and DAG. So when we are blocking, so all these are basically cyclic events. So after the signal transduction, the IP3 again comes for the next messaging system to conduct. So if we are blocking this, the cycle will be broken and there will be less the congener of the IP3 like the PIP2. So there is a depletion of the second messenger system and ultimately leads to less signal transduction. So they are completely absorbed from the GIT, long plasma half-life, not bound to plasma protein, not metabolized in the body, distributed in body fluids, slow entry into intracellular component, and its concentration can be detected in the plasma, saliva, urine. So this is important because this lithium is a very narrow therapeutic index drug. So you have already read about the therapeutic index in the general pharmacology. One of the prime example of this narrow therapeutic index drug is the lithium. And for narrow therapeutic index, in some of the cases, we should do some plasma drug monitoring. Already you have read about the general pharmacology, TDM. This is known as the therapeutic drug monitoring, TDM. So TDM can be done for this plasma or saliva or urine to see whether the drug is exceeds the toxic concentration or below the therapeutic concentration. Okay. So no effect in normal person, stabilizes mood in affective disorder, low therapeutic index, very important. Toxicity is correlated with plasma concentration like fine tremors, ataxia, confusion, delirium, convulsion, cardiac arrhythmia occurs. So this is also important, toxicity of the lithium. This is important for the exam also. Fine tremor is the most common toxicity that is associated with the lithium. Fine tremors of the hand. Treatment should be under normal sodium intake and normal cardiac and renal function because sodium and lithium are similar. They compete with one another. So normal sodium, that is the patient should not have hypo or hypernatremia. We have to check the sodium before giving the lithium. So lithium carbonate is clinically effective at plasma concentration in general 0.5 to 1. এটা মনে রাখবি ম্যাক্সিমাম কারো থেরাপিউটিক কনসেন্ট্রেশন লাগে না, বাস রিমেম্বার লিথিয়ামের থেরাপিউটিক প্লাজমা কনসেন্ট্রেশনটা পরীক্ষায় জিজ্ঞেস করে, তাই এটাই মনে রাখতে হবে, আর কোনো ড্রাগের লাগবে না। সো 0.5 to 1 নর্মালি 0.5 to 0.7 এরকম একটা রেঞ্জ আছে, বইয়ে দেখতে পাবি, কিন্তু মনে রাখার সুবিধার্থে 0.5 to 1। এবার 0.5 to 1 মানে খুবই ন্যারো রেঞ্জ, সেটা আবার মিলিমোল। 0.5 এর কম হলেই কোনো কাজ হবে না, 1 এর বেশি হলেই টক্সিসিটি হবে। So we have to do the above 1 mm, it produces variety of toxic effects. That's why plasma concentration therapeutic drug monitoring is needed. So therapeutic drug monitoring এর ক্ষেত্রে তোরা লিথিয়াম লিখতে পারবি। So example of the therapeutic drug monitoring: after the drug is started, 7 to 10 days must be elapsed before the antimanic effect is reached. Lithium causes depletion of the membrane, PIP2 already আমরা দেখেছি, full form phosphatidyl inositol, accumulation of intracellular inositol phosphate, hormone mediated CMP production is also reduced, all the second messenger system is reduced or depleted. Adverse effect: so there may be anorexia, diarrhea, hypothyroidism. Lithium can cause hypothyroidism, that is from the thyroid gland thyroid hormone release is decreased. Seizures can happen, epilepsy, leukocytosis, increased WBC count can happen. Nephrotic syndrome is a syndrome that happens in the kidney, that can happen. Polyuria, increased urine, impotence, all this can happen with the lithium. This is a toxic drug, and adverse reaction and dose and concentration dependent. Polyuria and polydipsia are frequent and reversible. So if we can decrease the dose, ultimately it is reversible. The principal physiologic lesion is the loss of ability of the collecting tubules to conserve water. That is, this lithium is like that of the sodium. Sodium basically conserve water. আমরা নুন দিলে কি হয়, সেটাকে ওয়াটারটাকে টেনে নেয়, লিথিয়ামের ক্ষেত্রেও তাই। So they are conserving water, and that's why there is more risk of the polydipsia or polyuria, increased urine or increased thrust when there is lithium toxicity. Edema can also happen. Frequent adverse effect of the lithium treatment: patient receiving lithium should avoid dehydration, that is, patient is asked to take more amount of the water. Cardiac adverse effect can happen like sick sinus syndrome. This is basically an alternative bradycardia tachycardia syndrome. This can happen by, and this can be observed by means of the ECG. So just remember, sick sinus syndrome is associated with lithium. Hypothyroidism can be associated with the lithium. Pregnancy ক্ষেত্রে lithium is transferred to nursing infants through breast milk, in which it has concentration about 1/3 to 1/2. So lithium toxicity in newborns is manifested by lethargy, cyanosis, poor suckling, perhaps hepatomegaly. That's why it should not be given to the nursing mothers. Drug interactions are there, details is not required, just remember lithium clearance has been associated in comparison to some non-steroidal anti-inflammatory drug, that is the NSAIDs, painkiller যেটাকে বলি, ibuprofen or indomethacin. Okay, so সেক্ষেত্রে toxicity হওয়ার সম্ভাবনা থাকে। So this is all about the lithium. Within the lithium you have to know about the mechanism of action in short. লিথিয়াম, প্লাজমা কনসেন্ট্রেশন, ন্যারো থেরাপিউটিক ইন্ডেক্স, এই ব্যাপারটা, এবং লিথিয়ামের অ্যাডভার্স এফেক্ট, ভেরি ইম্পর্টেন্ট, লিথিয়ামের অ্যাডভার্স এফেক্ট। অ্যান্ড apart from this, other drugs that can be used in mood disorder are the carbamazepine, valproic acid and lamotrigine. Just remember the name, you will read about this in the epilepsy chapter. Carbamazepine, mechanism of action, you will read about the epilepsy chapter. I am just showing the name: valproic acid, lamotrigine. Atypical antipsychotics, just we have read the risperidone, olanzapine and clozapine, that is used in case of the bipolar disorder. Atypical antipsychotic agents. And in some cases of the acute mania, যেখানে পেশেন্ট একদম রেস্টলেস, ঘুমাচ্ছে না, সেক্ষেত্রে আমরা ডাইজিপাম মানে বেনজোডাইজিপাম দিতে পারবো, ঠিক আছে? This is example of acute mania, euphoria.
Anyway, so our today's topic of discussion is ethyl alcohol. Okay, so like you raised your hands when I asked how many are non-Bengali. So how many are alcoholic here? One we gain from fermentation of grains. They are called beer, 3 to 6% alcohol. Nobody has taken, right? You are still small, you have time. Wine, 9 to 6% we get from grapes, fermentation of grapes. And the third category, which is most common, called the distilled spirit, include rum, whiskey, vodka, etc. They contain 40% alcohol. Now what is a standard drink? Standard drink is 400 ml of beer, 150 ml of wine and 50 ml of spirit. Alright. Like there is a common notion that you should, if you drink, you should drink within limit. To know that limit, you should have one unit to measure how much you are drinking. In that regard, you can think that this is a unit of how much you are drinking. One standard drink. One standard drink, it is recommended that women should drink not more than one standard drink in a day, and men more or less on a regular basis, and men should not drink more than 2 drinks per day, where one drink is equivalent to 400 ml beer, 150 ml wine and 50 ml of spirit. Now, why women should drink less? Is there any feminist here? Huh? Hey, who are the CRs here? তুই CR তো? আর কেউ CR নেই? তুই, তোরা দুজন CR? So, as a CR, as a class representative, you are representing as a leader of the girls here. So, why do you think that women should drink less? Why? Basically, metabolism of alcohol is faster and more in men, so men can tolerate more, and metabolism of alcohol is lower in female, so female can tolerate less. That's why standard drink duto male, in female 1. Alright. Now when one person takes a standard drink, in that person's body, this concentration of alcohol becomes, in that person's body, the concentration of alcohol becomes this, 0.03%. Auto detail, need not go into so much of details, 300 milligram per 100 ml, forget it. The percentage is 0.03%. When one person takes a standard drink, 0.03% is the concentration of alcohol in the body. It is quite acceptable. When you take 0.1 drink and it is 0.03% alcohol in your blood, you will be in a controlled state. But if you continue drinking more and more, gradually concentration of alcohol rises. And when it becomes 0.08, you are considered to be legally intoxicated. Mane legally matal hoye geche. Alright? Legally intoxicated. Oh, at that condition, the way you will behave and the way you will drive and the way you will function, that will not be safe, that is not legally acceptable. But if you go beyond that, you become very impaired. At normal functioning gulo, the normal function is gradually stop or gradually decrease. Control, you lose control over yourself. ঠিক আছে? And when it becomes more than 0.40%, it is fatal. It is fatal. Person will die of drinking. Pharmacology of alcohol, as a when you apply it on the skin, it acts as an astringent and antiseptic. Alcohol has an antiseptic effect. When you had COVID outbreak, hand sanitizers were in great demand. That hand sanitizers were made of alcohol. So alcohol is a very good antiseptic. In the central nervous system, alcohol causes depression. Shabhavik, it's quite natural. If you drink alcohol, you become sleepy. So it is a CNS depressant. It causes depression of alcohol, depression of the central nervous system. CNS depressant. On CV, and here are the various levels of alcohol in the blood, according to which how much CNS depression occur and the behavior of the person changes in this graph, whatever you say. Like in the lower range, there is only pleasure and excitement and euphoria. When you take 1 or 2 drinks, there is only pleasure and excitement or euphoria. And gradually, when you continue taking more, as the blood alcohol level rises, mental clouding, impairment of attention, impairment of memory, alteration of gait, drowsiness, these things start coming. When you drink further, the person becomes ataxic and drunk, cannot even stand properly, walk properly, and finally at the highest level, it will cause death. In general, people will not die out of alcohol because before this level is reached, the person will start vomiting. Okay? But if somehow a person manages to reach, like in our time, there were some great drinkers in our batch, internship, not in first, second year, during internship. So what they used to do is that before starting to drink, so that they don't vomit out, they want to enjoy the full pleasure of alcohol up to the level of death maybe, so that they do not vomit out. They used to take 8 milligram ondansetron injection, anti-emetic injection that reduces vomiting. At a very high dose they used to take. And after 1 hour of taking that injection, they will start drinking and drink and drink and drink, so that they don't vomit, and finally they will be ataxic. They will nearly reach this point, but none has so far died. Maybe they fall asleep before they reach the level where they will die out of drinking. But I have seen people controlling vomiting beforehand so that they can enjoy the alcohol. Okay? So, what is the effect on cardiovascular system? In small dose, alcohol causes cutaneous and gastric vasodilation. In a little more dose, in a moderate dose, it causes tachycardia. Sympathetic stimulation occurs, it causes tachycardia. In a large dose, alcohol causes reduction. This is the dose which becomes dangerous for the patient. In this dose, the large dose of alcohol, in this range, the higher range, the blood pressure drops, the cardiovascular center in the brain becomes suppressed and the blood pressure drops. Then body temperature, alcohol reduces body temperature. First it causes vasodilation and there is a feeling of warmth, but then there is excessive sweating and that results in fall of body temperature. Respiration, it causes respiratory depression, alcohol. And in the gastrointestinal tract, alcohol causes gastric irritation. Alcohol leads to gastritis. It's very common case you will get. Quite common case in the emergency where people will come with vomiting and pain abdomen. This is because of gastric irritation, because they have taken binges, they have done binge drinking, they have taken lot of alcohol. It leads to acute gastric irritation, acute gastritis. Alright? And this, I hope many of you know that when a person drinks a lot of alcohol, he or she has to go to the washroom again and again because alcohol causes a lot of urination, diuresis, and that occurs because alcohol causes suppression of the anti-diuretic hormone. That leads to a lot of diuresis. Act in the body. What is the physiology of how it acts in the body? Alcohol. It acts on various neurological pathways. First is the dopaminergic pathway. Dopaminergic pathway in the mesolimbic pathway. This is the mesolimbic pathway. In the mesolimbic pathway, it causes increase in the dopamine level. Increase in dopamine level leads to pleasure, euphoria, alcoholic craving. Pleasure, euphoria, alcohol. If someone takes alcohol, that person feels euphoric. There is a pleasurable effect in the lower dose mainly. There is a pleasurable effect and the person feels euphoric. This is because of this dopamine release in the mesolimbic pathway. Then serotonergic pathway. Can you see the last line, all of you? It's not visible. Serotonin level in the brain. Serotonin is the chemical mediator in the brain that causes a feeling of well-being. Mood elevation করে. It causes a feeling of well-being. ভালো ভালো লাগে. It causes well-being, a feeling of well-being. Serotonin. So alcohol increases serotonin level in the serotonergic pathway. Okay. Then there is a GABAergic pathway. GABA is an inhibitory neurotransmitter. ঠিক আছে? GABA is a inhibitory neurotransmitter in the brain. আচ্ছা, inhibition of the central nervous system leads to feeling of sleep, drowsiness, etc. So how should alcohol affect this system? It should stimulate this system or inhibit this system? Ball. Stimulate. Why? আমি কোশ্চেনটা কি করেছি? I have said whether alcohol should stimulate the GABA pathway or it should inhibit the GABA pathway. It should stimulate the GABA pathway. The result is inhibition, but it should stimulate the GABA pathway. Alright? Why? Because GABA is itself an inhibitory substance and alcohol is ultimately causing CNS inhibition. Next is the glutamate pathway. Glutamate is opposite to GABA. It's excitatory. Excitatory. তাহলে alcohol কি করবে? বল। Inhibit করবে, right? So alcohol should inhibit. হ্যাঁ? At that GABA, due to GABA activation, what happens? Sedation, loss of inhibited behavior, and there is relaxation. And due to glutamate pathway inhibition, there is reduction in cognitive function, reduction in attention, and impaired sleep-wake regulation, blackout phenomena. Impaired sleep-wake regulation ki hangover hoy. Even after a person who has taken significant amount of alcohol gets up next morning, he feels sleepy, drowsy, lethargic. That is called hangover. Alright? Someone who has taken significant amount of alcohol previous night, next morning will find himself or herself to be lethargic, sleepy, drowsy. That is called hangover, and that happens because the sleep-wake cycle is disturbed. Very important. Opioid are substances that are given from outside as well as produced in the body. Beta endorphin is a natural opioid that is produced in our body. What alcohol does, it binds to opioid mu receptor and causes release of dopamine. First, it causes release of dopamine, and that leads to, so first alcohol causes release of endogenous opioid beta endorphin. That beta endorphin leads to release of dopamine, and that leads to a pleasurable effect. Opioid leads to a pleasurable effect. Then alcohol causes opioid release, opioid causes dopamine release, and the person has a pleasurable effect. Similarly, endocannabinoids, another group of chemicals that are released by alcohol, that causes cognitive deficits and amnesia. Amnesia is forgetfulness. A person who has become alcoholic, who has taken significant amount of alcohol, often says a lot of things. Often pharmacokinetics ta ki? Alcohol absorption 20% from stomach, 80% from intestine, and peak level is reached within 30 minutes of drinking. Alcohol also causes the blood-brain barrier and placental barrier. তাই pregnant women দের alcohol restricted use করার কথা. Pregnant women should use restricted amount of alcohol, not prohibited, restricted. সোমশুক্র বোঝা গেছে? কি বোঝা গেছে? Restricted. Now, this is very important. This part is very important, and this part actually is the main part from where you get questions related to alcohol. Is the metabolism of alcohol. How is alcohol metabolized in the body? Let's see. Ethanol, that is alcohol, ethyl alcohol. When it reaches the cell level, after being absorbed and it reaches the liver, mainly it's metabolized in the liver. When it reaches the liver cells or the hepatocytes, it is mainly metabolized by the enzyme alcohol dehydrogenase. Alcohol dehydrogenase converts ethanol to acetaldehyde. Point 1. Acetaldehyde is quite a toxic substance. Acetaldehyde is quite a toxic substance. Acetaldehyde is then converted, because it's toxic, the body immediately converts it into acetic acid by enzyme aldehyde dehydrogenase. This acetic acid soon breaks down into carbon dioxide, water, and releases energy. First point, if someone drinks too much of alcohol, apart from this main pathway of metabolism, this side pathway also starts functioning, which is in the high doses, the microsomal oxidation, the enzyme CYP2E1. CYP2E1 is a microsomal enzyme in the hepatocyte. It converts alcohol. If there is excess of alcohol, it converts alcohol into free radicals. Free radicals. These free radicals cause liver cirrhosis. So if someone drinks lot of alcohol, excess of alcohol, for prolonged period, it can lead to liver cirrhosis because of this enzyme and because of microsomal oxidation caused by this enzyme. This is one important point. Why prolonged intake of alcohol in high doses can lead to liver cirrhosis. Next, if this enzyme is blocked, aldehyde dehydrogenase, if this enzyme is blocked, what do you think what will happen? Well, this concept is used in preventing re-addiction to alcohol. Someone has been de-addicted, an addict of alcohol, by various mechanisms, that addiction has been removed. Addiction has been removed. Now we don't want that person to go back to drinking. To prevent that, we use some drug. We use a drug rather. That drug blocks aldehyde dehydrogenase. So what happens? If the person again takes alcohol, the person is informed that if you take alcohol, you will be in danger. We are giving you a medicine such that if you take alcohol, you will be in danger. The person is pre-warned. In spite of that, if somehow the person experiments with even a small amount of alcohol, what will happen? Lot of aldehyde will get accumulated in the body. And that aldehyde leads to lot of painful symptoms like nausea, vomiting, headache, palpitation, even can lead to cardiovascular collapse if a lot of amount of alcohol is drunk. Why? Because acetaldehyde will accumulate in the body. That substance, that drug is called disulfiram. That drug is called disulfiram, which is a aldehyde dehydrogenase inhibitor. Disulfiram. And this reaction is called disulfiram reaction. Alright, this reaction is called disulfiram reaction. And apart from disulfiram, there are some other drugs that has disulfiram-like effect that can also block aldehyde dehydrogenase. Example is metronidazole, which is an anti-amoebic drug. Loosely, you can call it an antibacterial. Alright, so there are many other medicines that have disulfiram-like effect. Though disulfiram-like effect of disulfiram is highest, others don't have that much of aldehyde dehydrogenase inhibiting effect, but still some effects come. So the drugs that can inhibit aldehyde dehydrogenase, when a regular alcoholic person is prescribed that drug, that person has to be cautioned that you should stop drinking for the time being. Suppose a person has some GI problem because of his metronidazole has been given to that person. Then that person should be warned by the doctor, if the doctor is informed that he is an alcoholic, that you should not drink at least for the next 7 days when you will take this drug. Alright? Alright? So, we have a separate slide for disulfiram. Yes, this is the separate slide for disulfiram. Whatever I have discussed is written here. Okay, there is no need to write down in a hurry. You will get the PPT. I will give it to you. All of you will get it. So this is about the disulfiram reaction. This is a very important question. The aldehyde dehydrogenase is blocked. Okay, and there are many medicines that can cause this effect. Metronidazole is one example, and formaldehyde is very toxic. Much more toxic than acetaldehyde. Alright? And then formaldehyde is converted to formic acid. Acetic acid is not toxic. Acetic acid is almost a non-toxic substance. But formic acid is the most toxic of all that we have discussed so far. Highest toxicity, formic acid, then formaldehyde, then acetaldehyde. So if you take methanol, formaldehyde and formic acid both are very toxic substances. Formaldehyde and formic acid both are very toxic substances, and a classical toxicity they cause is optic neuropathy. চোখ নষ্ট করে দেয়. They disturb vision by causing neuropathy of the optic nerve. It would have been the best thing to do. But fomepizole is not an alcohol dehydrogenase inhibitor. We don't have a good alcohol dehydrogenase inhibitor. We have an aldehyde dehydrogenase inhibitor called fomepizole for methyl alcohol. Achha, but in the exam, what will be asked is how do you treat methyl alcohol poisoning with ethyl alcohol? That is the more interesting question for the examiners. মানে methyl alcohol poisoning হয়েছে, someone has taken methyl alcohol accidentally. To treat that person, we will give ethyl alcohol. So this is one place where quote unquote mod is being used as a drug, right? IV ethyl alcohol দেওয়া হয় কেন? We give IV intravenous ethyl alcohol in methyl alcohol poisoning. Why? Because this enzyme alcohol dehydrogenase has more affinity towards ethyl alcohol than methyl. So a person's body liver has both methyl alcohol as well as ethyl alcohol. You give ethyl, so person's hepatocyte has both ethyl and methyl. The enzyme in that hepatocyte alcohol dehydrogenase will go towards ethyl alcohol and not towards methyl. As a result, acetaldehyde will be formed and then acetic acid will be formed, and methyl alcohol will remain more or less as it is. Methyl alcohol will not be touched much. Methyl alcohol will not be touched much. So this is the preference of enzyme alcohol dehydrogenase. Preference of alcohol dehydrogenase towards ethyl alcohol. That is why we use ethyl alcohol in methyl alcohol poisoning. Methyl alcohol will remain as it is more or less, and the ethyl alcohol that we give from outside will utilize the alcohol dehydrogenase or divert the alcohol dehydrogenase enzyme to form acetaldehyde and then acetic acid. In that way, we will give some time to the person. We will give some time to the person, we will give some time to the health setup so that by some other way the methyl alcohol can be taken out of the body. There is a process called dialysis. By that process we can take out methyl alcohol from the body, but we need some time for that, and that time can be given by ethyl alcohol. Alright. So this is why ethyl alcohol is used in methyl alcohol poisoning. And another thing, when acetate or acetic acid breaks down, it produces CO2. It produces CO2. This CO2 is exhaled into the air. This is another question. CO2 is exhaled into the air. Have you seen drunkards, police checking whether people are doing drunk driving by holding a substance in front of their mouth and asking them to inhale and exhale? Have you seen in movies? South Indian movies I have seen. So, and this is nowadays also done quite commonly, at least in Kolkata, I have seen police doing it at night time. EM bypass hoy, Rubin More hoy, yete hoy, tor Baliganj অনেক জায়গায় দেখেছি আমি, ঠিক আছে? তো the principle behind using that machine is that, or that device is that CO2 will come out at a particular concentration and the device can detect that CO2. That CO2 indicates that this much of alcohol is present in the person's blood. This much of alcohol produces this much of CO2. There is a equation, and if a significant alcohol is present in the blood, then a significant amount of CO2 will be available in the exhaled air. That can be detected by the device. It is programmed in such a way. And then the police can get hold of that person that he is doing a drunk driving. Alright. So this is the basis of the breath analysis test. It is called breath analysis test. And this entire metabolism of alcohol alcohol dehydrogenase and aldehyde dehydrogenase is faster in men than women. That's why women are recommended to drink less. What are the side effects and toxicity of alcohol? Or more or less we have gone through this. Two important terms are here: Wernicke's encephalopathy and Korsakoff psychosis. These are two neurological side effects of chronic alcoholism. Wernicke's encephalopathy is when a chronic alcoholic suddenly drinks a lot amount of alcohol, a type of encephalopathy develops where the entire functioning of the brain is impaired and there are various neurological signs that are present. Wernicke's encephalopathy. And Korsakoff psychosis, it's a psychological, you can say a psychiatric disorder that alcoholics develop. The chronic alcoholics, you have probably seen in movies and all, they are a bit mentally and psychologically disturbed type of people. Most of them have Korsakoff psychosis. When a person has this psychosis, that person tends to forget things. And when they forget something, they will unknowingly lie to fill up those gaps. Alright, suppose that person has forgotten that he has eaten, or that person has forgotten that he has taken money from someone. Alright, now when someone asks to give back that money, that person unknowingly may say something that is not true. They try to, when they forget something, they try to put manufactured thoughts, that things that have not happened, they will put in the stories and they will make up a story. This is a type of psychosis that they develop, Korsakoff psychosis. And also there are some nutritional deficiency like thiamine deficiency, vitamin B12, folate deficiency, and these deficiencies lead to lot of neurological side effects. And that's what. And alcohol causes tremor. You should remember that one of the common side effects of alcohol is tremor, alcoholic tremor. These are just definitions. What is an alcohol abuse? Someone takes a high amount of alcohol, much beyond recommendation. That is an alcohol abuse, simply saying. And what is an addiction? These are definitions. I am telling you what the basic thing is. What is an addiction? Someone regularly takes alcohol and now cannot live without it. That is addiction. And alcohol has both psychological and physical dependence. when someone becomes addicted to a substance, it is said that that person has become dependent on that substance. That means the person cannot live without that substance. And alcohol has both physical and psychological dependence. Why? Physical dependence is because a person who has become used to alcohol, if they stop taking alcohol, they will have some physical problems. That leads to, that is called as physical dependence. Kichu physical problem, they will have some physical problems. And if they stop taking alcohol, they will have some psychological problems. What psychological problems? As you know, alcohol causes euphoria, dopamine, serotonin, all these substances causes euphoria, feeling of well-being. So if you have something in your life that causes feeling of well-being, and that substance is taken away from your life, then you will not feel good about it. You will suffer psychologically, and that is called as psychological dependence. Physical dependence is otherwise called negative reinforcement. Why? Because when a person becomes physically dependent on alcohol, that means that when a person who is dependent on alcohol, that person stops taking alcohol, he develops some physical symptoms, and these are the physical symptoms: anxiety, irritability, insomnia, tremor, delirium, hallucination. A person who has become dependent on alcohol stops taking alcohol and develop these physical symptoms: anxiety, irritability, insomnia, tremor, delirium, hallucination. So that person may not want to take alcohol, but because he is having or she is having these problems, the person will again have to take alcohol to get relief from these symptoms. So alcohol in a negative way is forcing this person. There is a feeling of well-being related to these. ঠিক আছে? What example I should give? Exam. Suppose exam. If you don't give exam, the college might put up your name in a list, might impose some fine, might send the data to NMC, and might ask you to repeat for 1 year, more year, and give fees for another more year. So you don't want to give exam, but because of the negative things that can happen to you, you are forced to give exam, right? So this is negative reinforcement. In a positive way, you are not being influenced to give exam. This is a negative way of forcing you to give exam. Similarly, if someone stops alcohol, these are the negative things happen to that person, because of which that person has to take alcohol again. That is why it is called negative reinforcement. Alcohol is negatively reinforcing itself on that person. But there is another positive reinforcement, that if you give exam, suppose the college says that if you scored well, you will be given a prize. Some of your fees will be curtailed. You might be, ঠিক আছে? You might be allowed to bunk some classes early next year. So this type of positive reinforcements are given to you. Then you will study and sit for the exam to get those positive things. Similarly, when a person leaves drinking alcohol, an alcoholic stops drinking alcohol, the reward that he gets from drinking, the reward, that is the feeling of well-being that he gets, that well-being stops. So to get that well-being, he will again drink. He is loving alcohol and drinking. So this is a positive reinforcement. So physical dependence actually leads to negative reinforcement, and the psychological dependence, that is the euphoric feeling, actually leads to positive reinforcement. Alright? So these are the two dependencies of alcohol. And because of these two dependences, leaving alcohol, that is abstinence of alcohol, becomes difficult. Physical problems occur. Someone who has become addicted to alcohol, if that person leaves alcohol, why the physical problems occur? The euphoria will not come is understandable. মদ খেয়ে আনন্দ পাচ্ছিল, মদ খাওয়া বন্ধ করলো, আনন্দ পাচ্ছে না, কারণ ডোপামিন সেরোটোনিন তৈরি হচ্ছে না। That is very easy to understand. The dopamine serotonin is produced in the brain because of alcohol. If you don't drink, those things are not produced, so the euphoria is not coming. The pleasure is not coming. That can be understood. But why the physical symptoms are occurring? That is because alcohol acts on so many systems we have discussed. Like it acts on the GABA system. It stimulates GABA. I have discussed in the beginning of the class. Alcohol stimulates GABA activity, it increases. It decreases glutamate activity. It increases serotonin activity. It increases dopamine activity. Any doubt about it? Yes or no? Alcohol এগুলো করে? Now, on a long-term basis, when alcohol does these things, the body also does the opposite. The body always tries to overcome a substance that is affecting it. The body does not want a substance to take control over it. Body always try to fight back. তাই জন্য body কি করে? What the body does, body tries to decrease the effect of alcohol in all these systems by doing the opposite. Like alcohol is increasing the GABA activity, body down regulates the GABA receptors. Body decreases the GABA receptors so that alcohol cannot cause much activity. The receptors are decreased by body because alcohol is stimulating GABA activity, body is decreasing GABA receptors. Because alcohol is inhibiting glutamate activity, body is increasing the NMDA or glutamate receptors. Clear? Opposite korche body. Because alcohol is stimulating the serotonergic activity, body is reducing the serotonin activity in the body, in the brain. Alcohol is causing increased dopamine, body is itself by various means decreasing the dopamine level. Clear? Now, if suddenly someone stops drinking, what will happen? These things, body has already turned down these things. So, there will be a loss of balance. Alcohol is no more in the system. Suddenly, alcohol is withdrawn. But these systems are turned upside down. Normal activity of GABA is not there in the body. GABA is down. GABA activity is down. Glutamate activity is more. So what happens? GABA reduces seizure. Glutamate increases seizure. Alcohol is no longer there. There is more glutamate activity. There is reduced GABA activity. There will be seizures. Alright? Because various systems, the body modifies itself to tackle alcohol. Suddenly when you stop alcohol, the body cannot again readjust back quickly, and that's why those symptoms start. Clear to all of you? Same thing, alcohol. Same thing is explained in this slide. Okay, you can go through this slide later. The same thing is explained, that there is increased GABA activity, body has reduced GABA receptor. Now because body has reduced GABA receptor, if we withdraw alcohol, the normal GABA that is present cannot act properly in the body. So there will be seizures because GABA prevents seizures. In similar way, serotonin, dopamine, all of them are affected. Alcohol was changing various pathways in a particular way. Body tried to pull it back. Now alcohol is no longer there. So what will happen? The way the body is pulling, it will asymmetrically go towards that side. To explain more easily, that suppose I and Swarnavu, we are trying to pull a thread and it is in a state of balance. Suddenly I move back, I leave the thread. What will happen? Swarnavu will fall with the thread on that side, the side where he was pulling. So that is what happens. Suddenly when alcohol stops, body was pulling itself in the other way, but now there is no alcohol left in the body, so body will simply fall on the other side. All excessive symptoms on the other side will happen. ঠিক আছে? Alcohol tolerance টা কিছুই না, it is the earlier stage of dependence. Before becoming dependent, tolerance develops. That means first a person was feeling euphoric and getting all the positive effects of alcohol by drinking suppose 2 drinks. After 6 months, 2 drinks will not act. He will need, for the same level of action, he will need 8 drinks. Why that happens? Because the body develops tolerance to alcohol. This metabolism, first of all, alcohol absorption reduces. Alcohol absorption reduces. If you chronically take alcohol, alcohol absorption reduces as the GI tract becomes damaged due to alcohol. And also these enzymes, alcohol dehydrogenase and aldehyde dehydrogenase, their actions also increase. There is enzyme induction. ঠিক আছে? Alcohol dehydrogenase and aldehyde dehydrogenase enzyme, they becomes more active if you continue taking alcohol. That's why at the beginning 2 drinks the body will take suppose 5 hours to handle. Now the body can handle that in 1 hour. Naturally the person will have to drink more. ঠিক আছে? Because the enzymes become more active. This is how tolerance develop. মানে the same amount of drink does not produce similar pleasurable effect. Management of chronic alcoholism, and both acute and chronic alcoholism management কিভাবে হবে? Suppose a person has taken lot of alcohol and is in intoxicated state. The first thing we do is, we are treating management of alcoholism. So a person, alcohol intoxication and management আমরা এখানে যাচ্ছি না। বেশি alcohol খেয়ে নিলে, if someone has taken a lot of alcohol, what will happen? We are not going into it. We are going into the treatment of chronic alcoholism. That means a person who used to drink regularly, we are stopping that alcohol. ঠিক আছে? We are stopping that alcohol. Now what will happen? Regularly he used to drink. Immediately after stop drinking, he will have those physical problems that about which we have discussed: irritability, palpitation, delirium, hallucination, agitation. So first we have to control these physical symptoms, the first 7 days. How we will control these physical symptoms? With the help of a drug called benzodiazepine. ঘুমের ওষুধ commonly যেগুলো হয়, ঘুমের ওষুধ বলে মার্কেটে যেগুলো চলে, benzodiazepine বলে। ঠিক আছে? If you have attended, some of you might have attended a lecture I have taken, I think last Monday. It was on benzodiazepine, মানে anxiolytics, sedatives, hypnotics. There we have discussed about benzodiazepine. So easily you can remember, they are the sleeping pills commonly used in market. ঘুমের ওষুধ, sleeping pills. So they are first given in the first 7 days. Those benzodiazepines are given, particularly chlordiazepoxide, diazepam. They are one of the common benzodiazepines that are given to calm down the patient, to reduce the acute discomfort, the physical symptoms. In the first 7 days, the physical symptoms are maximum. So to reduce those physical symptoms, first we have to give benzodiazepines. Apart from that, I told you alcoholics suffer from a lot of nutritional deficiency. So you have to give nutritional supplement in form of thiamine, folic acid, magnesium, etc. Now after the person has left drinking, and after we have managed the first few days of physical discomfort by some medicine, first few days of physical discomfort after we have managed, the next stage is to prevent that person from going back to drinking. And how that can be done, this again can be asked. ওরে ঘুমাস না আরেকটু how that can be done? অ্যালকোহলের ওয়েল ফিলিংটা কিসের থেকে আসে? ডোপামিন, সেরোটোনিন. Well feeling comes through dopamine, serotonin, and that dopamine comes through stimulation of some receptors. Dopamine comes through stimulation of some receptors. One of those receptors are opioid receptors. ঠিক আছে? the good feeling from alcohol drinking comes from something, some substances, one of which is dopamine. And that dopamine comes from stimulation of some receptors called opioid receptors. We block those receptors so that if the person again drinks after having left alcohol, he will not get that pleasurable effect. If he does not get that pleasurable effect, naturally the urge of drinking will reduce. So reduce the pleasurable effect by blocking the receptors that can produce the pleasure. That is the concept. These are called the anti-craving agents, naltrexone. We block the opioid receptors, and so there is reduction in craving to drink again, because even if they drink, they will not feel good. Okay? Then similarly, there is another substance called acamprosate that acts on NMDA receptor, that also acts in the same way. And then disulfiram, we have discussed that we tell the person that we are giving you a medicine. If you drink that medicine, first of all we have blocked the craving. Even if the person drinks, there will be no pleasurable effect because we have blocked some important receptors by acamprosate and naltrexone. Now we tell the person that you are being given a medicine. If you drink, you will have serious physical discomfort. The person will then try not to take. Even if by chance the person takes, what will happen? He will have no pleasurable feeling because already, or very less pleasurable feeling because already these anti-craving agents are being given. Pleasure asbe na because dopamine is blocked, and because of disulfiram, he will feel severe discomfort. So alcohol khelam, I get no pleasure, I get discomfort, so I will have less urge to drink next time. This is how it is being tried to bring the person back to normal life away from alcohol.
Caused by HIV, human immunodeficiency virus, which is of two types, type 1 and type 2. In India, which is most prevalent? Let's stick to the Indian subcontinent because we are in India. Type 2 is more common in Indian subcontinent. So, unfortunately, these have been kept intact. Means they are vacant. Nobody has occupied them, rather. So HIV, AIDS is caused by HIV, which is of type 1 and type 2. So, that is the causative agent of HIV. So, what? Okay, so the major salient features of HIV AIDS are, first of all, it's caused by HIV and it causes major immunosuppression. Remember, HIV affects two systems in the body predominantly. One is the immune system and the other is your central nervous system. One is the immune system and the other is your central nervous system. So we're sticking to the immune system, and it causes severe immune suppression, means your lymphocytes are affected. Okay, and because of immune suppression, this immune suppression gives rise to severe opportunistic infections. What kills a patient in HIV? What kills a patient with HIV? How does a patient of AIDS die? They die of various opportunistic infections. Infections which in a normal human being will not kill you, which in a human being with an intact immune system will be rendered harmless. Such kind of infections, when the immune system is depressed, when the immune system is down, because all the lymphocytes are depleted and the patient has severe immune suppression, these opportunistic infections flare up, and they are one of the major reasons of death in a patient, in an AIDS patient. So, caused by HIV, it leads to severe immune suppression. It causes severe immune suppression, which leads to opportunistic infections, because the immune system is depressed. Secondary neoplasms, various secondary neoplasms, and CNS manifestations. We are sticking mostly with the immune system here. So you know what HIV, it's well known to you which persons can be affected with AIDS? What is the main method of spread of AIDS? So, which population will be at risk? Homosexuals as well as heterosexuals. Homosexuals as well as heterosexuals. And if the homosexual person, those two guys, one of them is an intravenous drug abuser, if that person is an intravenous drug abuser, the chance of the partner getting affected by AIDS increases. Okay, so one is homosexuals and the other is heterosexual. So one is male to male transmission, male to male transmission, and the other is male to female transmission as well as female to male transmission. So male to female transmission, which indicates that the seminal fluid contains the virus, that is one thing, and as well as on the other hand, female to male transmission, which indicates that various vaginal secretions, the cervical cells, they can also be infected by the virus, with the virus. So they can spread the virus to their partner. So homosexuals and heterosexuals, and in case of heterosexuals as well as to a certain extent homosexuals, if they are affected with certain STDs like chlamydia, chancroid, gonorrhea, syphilis, again the chance increases. They basically act as a positive catalyst, or the chance is augmented. Quite obvious, isn't it? If the person is affected with sexually transmitted diseases and the person also have HIV, their chance of affecting their partner is very high. Right, so homosexuals as well as heterosexuals. Homosexuals and heterosexuals, they are the population at risk. Point number one. Point number two, intravenous drug abusers, sharing of same syringes, sharing of needles, very common in intravenous drug abusers. These are the population at risk. Examiner jigesh korte pare. So this answers must be at your fingertips. Homosexuals and heterosexuals. So that is one thing. Then you get the IV drug abusers, sharing of same syringe and needles. Number three, recipients of blood and blood components. Hote pare ki? Why is blood screened in a blood bank? What is the purpose of screening blood in a blood bank? Eta nishchoy tomra jano. You know now that blood is screened for certain diseases. So not only HIV, but the blood is also screened for other biohazardous diseases like hepatitis, various sexually transmitted diseases. Right? We do various serological tests on blood and blood products before we transfuse the blood to an individual. Okay, so recipients of blood and blood components. Now this risk has come down. This risk has come down to a major extent because of the availability of various tests which identify certain antigens, and I'm going to come to that. Which antigens? Okay, I'll explain. I'll come to that later. And one more thing, hemophiliacs who had received, hemophiliacs who had received concentrates of factor 8 and factor 9. Put your leg down. Factor 8 and factor 9. So these are the population at risk. Jigesh kortei pare, which people are affected by AIDS? So means the population at risk. Kon population, not that everyone can have AIDS. But there are certain people, certain lifestyle which predisposes an individual to AIDS. Homosexual and heterosexual, that's very much a lifestyle thing. IV drug abusers, yes, lifestyle thing. But hemophiliacs and IV and your recipients of blood and blood component, no. That is not lifestyle. That's definitely not lifestyle. You need it. Hemophiliacs need that factor 8, factor 9 blood products, recipients of blood and blood components. If they are unlucky, they may get, depending where the test is done, depending how much aseptic measures have been taken. So these are the population at risk. So after studying population at risk, my next slide is mode of spread. So quite obvious, sexual transmission. In homosexuals and heterosexuals, unprotected sexual intercourse, that can be one thing, unprotected sex. Then obviously in homosexuals and heterosexuals, that's common. The sexual method is one of the most common methods of spread of AIDS, and especially in countries like like third world countries like Africa. It's very common in sub-Saharan Africa and all. Okay. In developed countries, this has come down. That is one thing. Then parenteral transmission. What is parenteral transmission? Which one out of this is in parenteral transmission? IV drug abusers, recipients of blood and blood components, hemophiliacs who have been receiving recombinant factor 8 and factor 9. That is all parenteral transmission, means via needles. Right? And the last one is mother to infant. Mother to infant. How come a mother affect her infant? Transplacental spread. Transplacental, that is in utero. Right? Next one. While giving birth through an infected birth canal. That is number 2. And number 3, while she is lactating her baby through the breast milk. So these are the 3 methods where a mother can spread the virus to her baby. Okay, so there are 3 methods of spread. There are 3 modes of spread. If you remember this, that's more than enough. Now, how sexual transmission happens, what points can come under parenteral transmission and what points can come under mother to child transmission, that you have to go through the book. I'll just give you the heading and explain. Okay. So you get the sexual transmission, the parenteral transmission and mother to infant transmission. In mother to infant transmission, there are 3 methods. One is transplacental, that is in utero. Number 2 is through an infected birth, while giving birth through an infected birth canal, that is number 2. And you get the number 3, which is number 3? While feeding the baby, breastfeeding the baby through the breast milk, while lactating, during lactation. Okay, clear? Can I go to the next slide? Note, this is very essential. People will keep on asking you. People will ask you. Excuse me. AIDS এমন একটা জিনিস না, মানুষ মাথা খারাপ করে দেবে। Transmission occurs under conditions. এটা একদম বইয়ের লাইন আমি কপি করে দিয়েছি। Transmission occurs under conditions that facilitates exchange of blood and body fluids containing virus or virus infected cells. Otherwise হবে না কিন্তু। Okay? মানে এক স্কুলে বাচ্চা পড়লো, একজনের আনফরচুনেটলি এইচআইভি আছে, আরেকজনের এইচআইভি নেই, তখন কোয়েশ্চেন হতে পারে, can this kid sit next to my kid and study? Yes, of course he can. This is not a social taboo. All these people need is sympathy and treatment. That's all. So remember, transmission of HIV occurs under conditions that facilitates exchange of body fluids or blood, that is exchange of blood or body fluids which contains the virus infected cells. Okay, which contains the virus infected cells. Right? Good question. But if kono blood kokhono, you understand Bengali? Okay, see, blood will never be given without screening. Blood will be screened and given. Blood will be screened and given. Our blood থাকে না এরকম হয় না blood bank এ. All that happens is the blood is exchanged by another donor. Give and take policy. You give blood, I'm giving you blood. এইভাবে চলে, ব্লাড ব্যাংকে ব্লাড থাকে না এরকম হয় না। গুড। Yes. Yes, what's the problem? So before getting into the main topic, let me tell you a brief on the shape of the HIV virus. I think microbiology এটা পড়ানো হয়ে গেছে, but micro will teach you much better than I do because it's a micro topic. So আমি just ভাইরাসটা দেখিয়ে দিলাম। The virion is spherical shaped. This is the virion which is spherical shaped and it has a cone shaped core. It has a cone shaped core, and this core contains the major capsid protein which is called as P24. Now, out of all this, why I have underlined it and made it bold? Why? Any guess? What is the importance of knowing P24 antigen? Baki bhule jao, but don't forget the P24 antigen. Why? That's the only reason why I have made it bold and I have underlined it. Because when you do a screening test, for HIV, it's basically an antigen-antibody reaction, right? So this P24 antigen is the particular antigen which is targeted by the antibody when a serological test for HIV is done. This is the particular antigen that is identified. So once the P24 antigen is identified in a patient's blood, P24 antigen is positive, this means the patient has HIV. That is the only reason why I have highlighted it. Nucleocapsid protein P7 and P9, nucleocapsid protein P7 and P9, two genomic RNA copies, and 3 enzymes. So these are the 3 enzymes: protease, reverse transcriptase, and integrase. আমি এখানে আর বেশি জোর দিচ্ছি না. So it's a cone shaped, the virion is cone shaped, spherical shaped with a cone shaped core that has a lipid bilayer. তার মধ্যে remember the P24 antigen, which is the main target of the antibodies. Then you get the nucleocapsid proteins P7 and P9, then 2 genomic RNAs and 3 enzymes: protease, integrase, and reverse transcriptase. Etuku jano, that is more than enough. So what are the major targets of HIV, which I just told you, are the immune system. The immune system, which is why we always look for the lymphocyte count, which is why we always look for the Panami. We always look for the lymphocyte count. Okay, so the immune system, the main cell is the lymphocytes. Then you get other cells also like macrophages, dendritic cells, and when the CNS is affected, the central nervous system, the microglial cells are also affected. So the major targets of HIV are the immune system, which I have told you in the beginning, and the CNS, that is the central nervous system. So when we talk about the life cycle of HIV, how does HIV occur? Just remember, there are 3 things. One is the virus entry. The virus entry. So when we talk about the virus entry, we need to know about various receptors. We need to know about the various receptors and co-receptors. So which is the most important receptor? CD4. The most important receptor that you must know is the CD4. What is CD? Cluster of differentiation, which is present on the lymphocytes. And this explains the tropism of the virus for lymphocytes, macrophages, and dendritic cells, as well as monocytes, because they express that CD antigen on the cell surface. So you need the CD antigen on the cell surface. Now that is one thing. This explains the reason why they prefer lymphocytes, macrophages, monocytes, dendritic cells so much, because they have the CD4 surface on their antigen. This is what I am talking about, the CD4. Now CD4 is not enough. Along with receptors, you need various co-receptors, and these are the chemokine receptors. Like CCR4, CX, CR5. So these are the various chemokine receptors. একটা ট্রেন কি করে ইঞ্জিনে লাগে, একটা ইঞ্জিন কি করে ট্রেনে লাগে দেখেছো? Have you ever seen how coupling occurs? At least Indian scenario তে, আমি ওয়েস্টার্ন সিনারিও বলছি না। ইঞ্জিনটা লাগার পর there's a person who stands between the compartment and the engine and who takes that lohar jinis, that thing, that pulley kind of thing, and fixes it. So one is not enough. Similarly, in HIV infection, only attachment to CD4 is not enough. You also need various other co-receptors like chemokine receptors, CX, CR4, CCR5, and by attaching to them, the GP41, GP120, just remember the names, they attach to these chemokine receptors and co-receptors, and the virus gains entry into the the virus gains entry into the cell. Now inside the cell, the virus er ki ache RNA, right? It has to integrate with the host cell genome. It has to integrate with the host cell genome. Amader ki ache? What do we have? We have DNA. This virus has RNA. Now, based on your biochemistry knowledge, what can happen next? Yes. Ki hobe? Reverse transcription. Right? The RNA must undergo reverse transcription. And which enzyme does this? Reverse transcriptase. They form cDNA. They form cDNA. What is cDNA? Complementary DNA. Right? কি বলেছিলি তুই? হ্যাঁ? সার্কুলার ডিএনএ না ঠিক আছে হতে পারে আমার মতো নলেজ আমার জানি না ভাই আমি যতটুকু আমি জানি বলছি so they form the RNA forms cDNA that is complementary DNA. Now this complementary DNA in quiescent cells remains in an episomal form in the cytoplasm. They do not enter the nucleus. In quiescent cells means cells which are non-dividing. In dividing cells, the cDNA circularizes with the host cell genome, the nucleus, and it gets integrated in an episomal form. And it gets integrated with the host DNA in an episomal form. So the virus replication begins. Non-dividing cells are noy. It begins in the dividing cells. The virus replication occurs in the dividing cells, and finally the virus forms various virions. It forms various blebs, and the mature virion is ultimately released, causing havoc. So this is basically the life cycle of the virus. The virus must enter with the help of various receptors and chemoreceptors, that is the CXCR4, CXCR5, that's the co-receptors, receptors and co-receptors, that is one. Then the virus, because it has RNA and the humans have DNA, it has to change. The RNA undergoes reverse transcription and forms cDNA, complementary DNA. Which enzyme does this? Reverse transcriptase. Now the cDNA that is formed remains in a linear episomal form in the quiescent cells, the cells which are non-dividing. Only in the dividing cells they get integrated with the host genome, and finally they start replication, and finally the virus particles are released. Mature new virions are released. New viral particles are released. Okay, so this is, in short, this is a very big thing. Microbiology will explain you in more details. But now let me get into the pathogenesis. Let me get into the pathogenesis, the evolution of. So this is the tropism which I have just mentioned. Tropism means bhalobasha, kar proti bhalobasha. There's viruses have tropism for lymphocytes because of all the CD4 things. So viral tropism refers to which cell types the HIV infects. CD4 cells, macrophages, dendritic cells, microglial cells in case of CNS, which I have just explained, then various receptors and co-receptors which I have already mentioned. আমাদের একটা ভুল লিখেছি ওখানে anyway CCR5 হবে CXCR4 আমি ভুল লিখেছি sorry anyway just write this because this is from the book that I didn't remember. So whatever, so these are the various M-tropic virus. Just remember the name, which is tropism. This M-tropic virus are the virus which is tropism for the macrophages. Then you get various T-tropic viruses. These M-tropic viruses are the ones which is present in the acute phase of the disease, whereas with time the T-tropic viruses are present in the blood. So it depends on which type of co-receptors they use for entry into the cell. So you have M-tropic virus, then you get the T-tropic virus which uses the chemokine receptor CXCR4, and then you get the dual-tropic virus which uses both CCR5 and CXCR4. That is why they are dual-tropic. Okay, leave that. Coming to the phases of evolution. coming to the phases of evolution, this is important. The first thing is primary infection with virus dissemination and acute retroviral syndrome. That is the first phase. I'll explain in details. The second phase is phase of chronic latency. This is basically an asymptomatic phase basically. And the final one is when everything, all the immune system is broken down, what you call is AIDS. That is the final one. So first is virus primary infection, virus dissemination in the body and acute retroviral syndrome. That is one. Then number two, chronic infection or phase of clinical latency where the patient is predominantly asymptomatic. And the final one is the full-blown AIDS. Excuse me. Final one is the full-blown AIDS. So now what can happen? If you look into this picture, so how does a HIV virus gains entry into the body? My first question is, how does a virus gains entry into the body? One can be in the blood because of a breach or trauma in the blood vessels. Other can be the infection of the what? The lymphocytes or the microglial cells or the dendritic cells. The CD4 plus cells. Ekta hote pare, there is a breach in the blood vessel through which the virus gains direct entry into the blood. Arekta ki hote pare? The virus infects the lymphocytes. Yes, the virus infects the lymphocytes or the CD4 plus cells, the microglial cells in the CNS or the dendritic cells or the macrophages. So that is the mode of inoculation of the virus in the body. So in the first place, what happens is in primary infection, the virus enters through the mucosal tissue. The virus enters the mucosa and affects the helper T cells as well as the memory T cells. And because the mucosa is one of the most important reservoirs of T cells, whether helper T cells or memory T cells, the infection of these T cells cause massive death of these cells. So what are these T cells basically? Which lineage? They're lymphocytes, right? B lymphocytes, T lymphocytes. So T lymphocytes are the ones which are affected the most. So because the virus infects the T cells the most in the mucosal tissue, the T cells are depleted. Many T cells die. Now, the dendritic cells which are present at the site of the virus entry, they catch the virus. The dendritic cells, they basically catch the virus and present it to the lymph nodes. They present it to the lymph nodes. Fine, the dendritic cells, what are dendritic cells? Their immune system is over. What are they called? APCs. Very good. What is APC? Antigen presenting cells. Very good. So, you know dendritic cells, the virus is basically an antigen, right? The virus is seen as an antigen. So, the APCs, the antigen presenting cells, will catch the virus, that is, will catch the antigen and present it to what? To the lymphoid tissue. এখান থেকে কিচ্ছু দেখা যাচ্ছে না, আমি এখান থেকে দেখতে পাচ্ছি না, সামনে না এলে বুঝতে পারবি না। Anyway, so an infection is established in the lymphoid tissue. An infection is established in the lymphoid tissue. ঠিক আছে? So during this phase, many lymphocytes die. During this phase, many lymphocytes die. But the body is not sitting down idle either. শরীরে একটা ইনফেকশন ঢুকেছে, there is an intruder, so the immune system will get activated. So your humoral and cell mediated immune system will get activated and it will mount a antibody response against the virus. It will mount an antibody response against the virus. And this is manifested by something called seroconversion. This is manifested by something called seroconversion. So, তোমার infection হওয়ার somebody's infection হওয়ার after 3 to 7 weeks, that is the phase of seroconversion. What is seroconversion? Micro থেকে, based on your micro knowledge, tell me what is seroconversion? মানে কি হয় সেটা? মানে বেসিক্যালি একদম পাতি ভাষায় বলো। the point of entry of the virus in the body till the time when antibodies are found in the blood. এই যে 3 to 7 weeks মানে শরীরে একটা ইন্ডিভিজুয়ালের ভাইরাস ঢুকলো, তারপরে যে অ্যান্টিবডিজটা ডেভেলপ করছে, which takes around 3 to 7 weeks, this particular period এটাকে বলা হচ্ছে উইন্ডো পিরিয়ড. This is called the window period, right? তো এই 3 to 7 weeks এর পরে যখন অ্যান্টিবডিজ ডেভেলপ করলো, which means your body is mounting a defensive response against the virus, and that is called as seroconversion, which takes around 3 to 7 weeks. Right? So this is what I have given. There is depletion of memory T cells with viral dissemination and host immunity development. This is followed by acute retroviral syndrome. Is this clear? Virus first of all শরীরে ঢুকলো through the mucosa and infects and kills many T cells. Then the APC, the antigen presenting cells, they catch the virus and present it to the lymph nodes. Lymph nodes গিয়েও কিন্তু virus havoc করছে. They are still killing the lymphocytes in the lymph nodes. শরীর চুপচাপ বসে থাকবে না. The body will mount a response, a defensive response. A defensive response is characterized by formation of antibodies against the virus, and this is called a seroconversion. The point of entry of the virus in a human body till the time the body starts developing antibodies against the virus, that particular thing is called that particular is a window period, and when the virus mounts a response, that is called as seroconversion. So this is called as seroconversion, which takes around 3 to 7 weeks post exposure. Now the viral titer begins to fall and the CD8 and CD4 counts begins to rise. এখন কিন্তু viral RNA খুব একটা পাওয়া যাচ্ছে না, because the body is fighting against the virus. So this is when there is control of viremia and viral RNA levels are at a very low detectable levels. The viral RNA are at a very low detectable levels, which occurs 12 weeks post exposure. During this period, patients can develop something called as ARS. What is ARS? Acute retroviral syndrome. Acute retroviral syndrome, which is characterized by sore throat, myalgia, fever, diarrhea, weight loss. Fever, diarrhea, weight loss. Okay. Kintu, there's one more thing again you have to remember, which happens in this phase. After some time, the immune system slowly but steadily starts to fail. The immune system slowly but steadily starts to fail. And at the end of this phase, at the end of this primary dissemination phase, if we do a blood count, we see that the viral RNA levels and the CD4A and the CD8 or CD4 counts are at an equilibrium. They have reached a plateau, which means that the body is slowly but steadily losing the battle against the virus. That is called as a viral set point. And we do it, there are two ways to do it. We do a CD4 count and we check for the plasma RNA levels, plasma viral RNA levels. Okay. Then comes the middle chronic phase. The middle chronic phase is known as the phase of clinical latency. The phase of clinical latency. Here the patient is mostly asymptomatic. But some of them can present with, say, oral candidiasis, vaginal candidiasis. Oral candidiasis is known as thrush. Then the patient can present with vaginal candidiasis or certain CNS manifestations So these are the various manifestations the patient can present with. Some of them can present with Mycobacterium tuberculosis infection. Okay, so this is the phase of clinical latency, but mostly patients are asymptomatic in this phase. That's why it is called the phase of clinical latency. But remember, what happens here is the body is again losing the battle against the virus. Inside the body, the virus, the immune system is fighting against the virus, and the body's approximately 10 to the power 12 lymphocyte count is slowly but steadily coming down. The plasma viral RNA levels are increasing. If you do tests, you can make out. But the point is, because this is a clinical latency period, most patients are asymptomatic. People do not have much idea that they are slowly but steadily on the verge of a decline. Okay, so this is the middle chronic phase or the phase of clinical latency. And finally comes the full-blown infection, which is known as, so this is the chronic phase. If you want, you can take the slides. যা আমি বললাম এখানে সেটাই আমি ওখানে লিখেছি। ওকে, এগুলো আমি বানিয়েছিলাম অন্তত 4-5 বছর আগে, when I used to write a lot। এখন আর আমার লেখা ধৈর্য নেই, সেই জন্য আমার নিউ স্লাইডসে you won't find me writing too much। এটা আগেরটা থেকে আমি কাট কপি করে দিয়েছি। আমার পুরনো একটা স্লাইড ছিল, এটা আমি কেপিসিতে পড়িয়েছিলাম 2017-এ, সেইটার থেকে আমি কাট কপি করেছি। So the final one is AIDS. The final one is AIDS, where it's a full-blown infection where the patient gets various opportunistic infections and fever, weight loss, diarrhea, everything continues. Everything continues. So that comes under, and you get various CNS neoplasms, you get various other tumors like the Kaposi sarcoma, cervical carcinoma, anal carcinoma, etc., etc. Various opportunistic infections sets in, and they come under the rubric AIDS indicator disease. If you see the book. So there is destruction of the lymphoid, tissues and depletion of the CD4 plus T cells. There is full-blown AIDS. So these are the three phases: primary dissemination, acute retroviral syndrome, and the phase of clinical latency, and finally the AIDS. So that is the natural evolution of AIDS. So there are a few things which you should know: rapid progressors, long-term non-progressors, and elite controllers. What are these things? তোমাদের জিজ্ঞেস করবে না এগুলো, but just explaining it to you, what is a rapid progressor, what is a long-term non-progressor, and what is an elite controller. What is a rapid progressor? What is a rapid progressor? The middle chronic phase is telescoped to just 2 to 3 years. Very unfortunate. 2 থেকে 3 বছরের মধ্যে they develop full-blown AIDS. What is long-term non-progressors? What is long-term non-progressors? Means they have very low plasma RNA levels. For 10 years, 15 years, they don't progress at all. Good for them. And the final one is elite controllers. Elite controllers. What is an elite society? Hi-Fi, right? Top brands. Top brass remains in the elite society. So এখানে এরা হচ্ছে AIDS পেশেন্টদের মধ্যে এরা elite, মানে এদের প্লাজমা লেভেলস আর প্লাজমা RNA levels are like say 50 to 75 copies per ml. এত কম। So very, 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 very low levels of plasma RNA in the blood. So they are elite controllers. So rapid progressors, long-term non-progressors, and elite controllers. যাক আমি এখন সবাই যেতে চাইছি জানি। So the thing is, so when we say that, I mean, this is the reason why I haven't taken the class at 9:30. I could have started at 9:30. তারপরে অগ্নিকের ক্লাস ছিল, আমি ওরা একই সঙ্গে এসেছি ইনফ্যাক্ট, আর I could have started it at 9:30, তাহলে ওদিকে পিছিয়ে যেত। So I felt like no, I'll take at 3 o'clock only. Then comes AIDS. In AIDS, there is total breakdown of the host defense with a CD4 cell count, CD4 plus T cell count less than 200 per microliter, less than 200 per microliter, with high risk of opportunistic infections and neoplasms. Okay. So this, you can just go through it. These are the various opportunistic infections in AIDS. I'm not explaining them. These are the various it's going to take a lot of time at the postgraduate level. Just remember that there are various protozoal and helminthic infections like pneumocystosis, cryptosporidiosis, isosporidiosis, etc., etc., toxoplasmosis. Then you get the fungal infection, candidiasis, which is by far the most common. Then various bacterial infections like the mycobacterial infections. Then viral infections, herpes zoster, herpes simplex, etc. Then various neoplasms, Kaposi sarcoma, anal cell carcinoma, cervical carcinoma, then central nervous system lymphoma. That is very deadly. The central nervous system lymphomas are by far the deadliest of the lot. Okay. পুরো সবকটা ছবি আসেনি কেন আমি জানি না। So you can make out how much cachexic. See, এই পেশেন্টটাকে দেখে তোমার মনে হতেই পারে it's a cancer patient. Right? পুরো ক্যাকেক্সিয়া হয়ে আছে না, thin, emaciated, পুরো loss of muscle mass and all. পুরো আরো দুটো ছবি ছিল, কেন আসেনি আমি জানি না। What is this? What is this? This one, thrush, oral candidiasis. That is known as. হ্যাঁ এটা আসেনি। ও পেয়েও গেছো? ওটা আসেনি, আগেই নিয়ে নিচ্ছে। ও আচ্ছা okay, fine. So these are various oral candidiasis and all. Just remember these pictures. And finally the tumors. You get Kaposi sarcoma, the lymphoma, which can affect any part of the body. By far the most dreaded is the central nervous system lymphoma, and then others like cervical carcinoma and anal carcinoma. That finishes the topic on AIDS, and that finishes the topic on immune system. Now, how we are going to go is, because we have new students here. Congratulations that you are here. Thank you so much.